topic, which is role of IHC in tissue biopsy diagnosis. This is going to be presented by Dr. Rachel. She's the Deputy Coordinator and HOD of Pathology at KIMS Health in Trivandrum. She has her areas of interest are GI, hepatobiliary, renal, and oncopathology. Has published multiple case reports and articles in journals of national repute. And her forte is frozen section, immunohistochemistry, interpretation, and immunofluorescence. Over to you, Dr. Rachel.
Thank you, madam. Thank you, Dr. Simi ma'am, for the very kind introduction. So I'll straight away go on to my topic, that is the role of immunohistochemistry in tissue biopsy diagnosis. My aim will be to provide an overview of some of the common IHC markers which we use tissue diagnosis. So Krishna ma'am has given an overview of the principle of IHC. If we look at the workflow of a IHC in tissue biopsy, here we have a tissue section on the glass slide, and we apply a primary antibody to the section, and if the antigen which we are looking for or the target antigen is present in the tissue, there will be an antigen antibody complex forming. And once this complex is formed, a secondary antibody is going to come and bind to this complex in order to enhance and amplify the reaction signal. And as the secondary antibody is tagged to an enzyme substrate, this interaction results in the formation of a colored product which is precipitated at the site of the antigen antibody reaction. So this colored precipitate is then visualized on the slide under the light microscope, and we have to localize the target protein as to whether it is in the membrane, in the cytoplasm, or in the nucleus, and this interpretation we are able to do in the background of morphological features. So straight away going on to the role of IHC in tumor classification, subtyping, and grading. If we come to one of the carcinomas in which the use of IHC is indispensable, that is lung carcinoma. Primarily, the aim is the differentiation of adeno versus squamous cell carcinoma. Why is this important? Because targetable driver mutations for which drugs are available are mostly identified in adenocarcinoma. So the adenocarcinoma markers which are used include broad cytokeratin CK7 and the tissue-specific markers, that is thyroid transcription factor 1 and napsin. Squamous cell markers include P40, P63 and CK5R6. Of this, P40 is the most specific. So how does IHC help us? For example, if you have a small biopsy in which we are able to see only a solid pattern of a tumor with no clear adeno or squamous differentiation, and we are not able to demonstrate mucin, if by IHC it's coming positive for one of these markers, we are able to classify the tumor rather than labeling it just as a large cell carcinoma. Also, we know that adenocarcinomas from various sites can look similar under the microscope. And since lung is a known metastatic site, it also helps to confirm the tissue of origin. Once you diagnose an adenocarcinoma, then reflex testing for driver mutations like ALK, ROS, and EGFR by IHC or NGS is carried out for making therapy decisions. So just to show an example, this was a 55-year-old male with a right upper lobe lesion presenting with massive pleural effusion and mediastinal adenopathy. We received a fluoroscopic biopsy. So as you can see here, the tumor is composed of very large polygonal cells having highly pleomorphic nuclei with no clear glandular pattern or evidence of a squamous differentiation. So we applied a panel of markers. The tumor showed strong nuclear positivity for TTF1, and though napsin staining was patchy, we could see cytoplasmic granular positivity in many of the tumor cells. The squamous marker P40 and the neuroendocrine marker synaptophysin was negative. So IHC confirmed a metastasis from a pulmonary adenocarcinoma. The next role would be in lung neuroendocrine tumors. One important point to remember is that just the expression of a neuroendocrine marker, for example, synaptophysin, doesn't label a tumor as neuroendocrine. You need to have a classic neuroendocrine morphology along with positivity for at least one of the markers, synaptochromo or CD56, along with the Ki67 proliferation index, helps us to classify the tumors as carcinoid, whether typical or atypical small cell lung carcinoma or a large cell neuroendocrine carcinoma. Another situation is if you have a peripherally located tumor and the patient is presenting with massive pleural effusion and multiple nodular pleural deposits, malignant mesothelioma is always a close differential. So the markers which you can use for mesothelioma include calretinin, podoplanin, molecule D240, CK5R6, and WT1. For adenocarcinoma, as already mentioned, apart from TTF1 and napsin, you can use broader adenocarcinoma markers like CEA, BUR-EP4, and MOC31, which will help us in the differentiation. Now, if you have an endobronchial based tumor in a relatively young adult, be careful not to miss out on a salivary gland tumor. If you're suspecting a salivary gland tumor, you can apply a panel of luminal markers, that is CK7, CEA, CD117, and myoepithelial markers such as S100 and P63 to confirm your diagnosis. Just a classical immunohistochemistry result for a neuroendocrine carcinoma. In pan-CK, you can see that there is a paranuclear cytoplasmic dot-like positivity characteristically seen in neuroendocrine tumors. It was positive for synaptophysin and CD56, Ki67 very high, up to 90%, and TTF1 was also positive. So this was a case of a metastasis from a small cell neuroendocrine carcinoma confirmed by IHC. Coming to invasive breast carcinomas, generally in early stage breast cancers, we do not need to do any tissue specific markers on a routine basis unless we have a highly advanced stage disease with multiple metastatic sites. Generally, the invasive breast carcinomas are positive for CK7, E-cadherin, GATA3, GCDFP15, and mammoglobin. 30% of the breast carcinomas can express basal markers like CK5R6 and EGFR. P63 expression can be seen in metaplastic and salivary gland-like carcinomas. P63 is also a very useful marker when you have a a problem scenario of adenosis versus a tubular pattern of a low-grade invasive breast carcinoma. So P63 can help you in this situation because the myoepithelial markers will be positive or preserved in a case of adenosis or benign breast duct, and they will be lost in a case of carcinoma. So by protocol, what is absolutely necessary is the assessment of ERPR status and HER2 status of IBCs, since it is indispensable for therapy decision making. So the most widely method which is used to assess the receptor status in invasive breast carcinomas is by the Aldred score, where you look at the proportion of the tumor cells which are positive for ER and PR, and also look at the intensity of staining, that is, whether it's a strong staining, a moderate staining, weak staining, or no staining at all. And you arrive at a final score by adding the proportion score along with the intensity score. If the score is 0 and 2, it is negative for hormone receptors, and a scores of 3 to 8 label it as a hormone positive invasive breast cancer. Why is this important? So evaluation of these IHC biomarkers, that is ERPR, HER2 status, along with the Ki67 proliferation index, helps in the molecular subtype classification of breast carcinoma. So using these markers, we can classify it as a luminal A-like, that is, which are luminal tumors, non-luminal tumors, and triple negative tumors. So the luminal tumors, you can have luminal A type, which are positive for the hormone receptors and negative for HER2, luminal B type, which are always hormone positive, but they can either be negative or positive for HER2 with a key index which is usually high. Then you have the non-luminal HER2 enriched tumors in which HER2 is positive, but the receptor markers are negative. And of course, the triple negative tumors or the TNBCs, which are negative for all the three receptors. So this classification acts as a prognostic and predictive marker because, as Krishna ma'am mentioned, this will help to predict the response of the tumor to either endocrine therapy or an anti-HER2 targeted therapy, or allows the clinician to make a decision regarding the need for an adjuvant chemo. Now, when coming on to the IHC markers for lymphoma diagnosis and classification, this is a very vast topic, but I'll just try to give an overview of the common markers which we use. First, we have the CD45. So that is the leukocyte common antigen, which is present in all hematopoietic cells. Basic purpose is to differentiate between a hematological and a non-hematological malignancy. Next, coming to the B cell lineage markers, the most commonly used CD marker is CD20. Apart from CD20, for identification of the B cell lineage, you can also use other pan B cell markers like CD19, CD22, CD79A, and also B cell transcription factor proteins. They help in B cell differentiation and maturation. Examples include PAX5, OCT2, and BOB1. The use of these additional B lineage markers is especially useful in some lymphomas which can be CD20 negative. For example, an anaplastic large cell lymphoma or a plasmablastic lymphoma, they are usually CD20 negative, and the application of these additional B lineage markers will help you to identify the B cell lineage. Another very important IHC marker for B cell lymphoma diagnosis is BCL2. It is an anti-apoptotic protein. It is aberrantly expressed in B cells. That means it's absent in a normal or a reactive B cell, but its positivity will mark the label as or label the B cell as neoplastic. Next, coming to additional markers which are used for DLBCL categorizations include the germinal center markers, CD10 and BCL6, and the activated B cell marker MUM1. Coming to T cells, the most commonly used T cell lineage marker is CD3. Apart from this, you can also use pan T cell markers like CD2, CD5, CD7, CD4, and CD8. ALK used to identify the ALK gene fusion in anaplastic large cell lymphomas, and also CD15 and CD30, as we all know, used to identify the Reed-Sternberg cells in Hodgkin's lymphoma. So using these panel or a basket of markers, we can build up diagnostic lymphoma panels. But before we go further, I would like to make the point that whatever panel you choose, it has to be based on the morphology. So suppose you are suspecting a low-grade B-cell lymphoma, you have a monotonous population of small lymphoid cells seen either as nodular aggregates or sheets, you go ahead with this panel. So the essential panel for a small or a low-grade B-cell lymphoma has to include the lineage markers CD3 and CD20, BCL2, which will label the B-cell as neoplastic and rule out a reactive process, CD10 to identify the germinal center lineage, and Ki67 to grade the lymphoma. So here you have an example of a follicular lymphoma. This is very useful, like if you have a lymph node which is showing a florid reactive follicular hyperplasia and you are in doubt whether it's a lymphoma or just a reactive process. The expression of CD10 in the follicles along with the BCL2 positivity labels it as neoplastic. It rules out a reactive process and confirms the diagnosis of follicular lymphoma. Additional categorization markers which you can use include CD5 and CD23 for CLL bar SLL, and cyclin D1 and SOX11 in cases of mantle cell lymphoma, then CD138 kappa, lambda, IgD, and IgM can be used for marginal zone lymphomas and lymphoplasmacytic lymphomas. Next, coming to diagnosis of DLBCL and its variants. So here the morphology which you would expect is of a diffuse infiltrate of large lymphoid cells with plenty of mitosis and apoptosis. Again, the essential panel has to include CD3, CD20, BCL2 and Ki67. Also, you have to include the proto-oncogene marker c-MYC. And as I mentioned, when you have a DLBCL, you have to then further categorize the cell of origin using the markers CD10, BCL6 and MUM1, and also look for the double expressor status, that is BCL. Double expressor means you have a DLBCL which is positive for both BCL2 and c-MYC. Why is this important? This is because in some protocols or in some studies, the activated B cell type of DLBCLs have shown to have a lesser response to standard R-CHOP regimens. Why is the double expressor status important? In cases where the DLBCLs show a double expressor status, especially when they have a high key index, there is chance that it could be a double hit lymphoma, and so the clinician may send the tissue for molecular studies to look at BCL2 and c-MYC gene rearrangements. The importance is that if you identify these rearrangements, the patient may be offered a aggressive chemotherapy regime. Apart from this, the further markers which can be used for subcategorization of the variants of DLBCL include CD23, which is possible in primary mediastinal large B-cell lymphomas, CD30 and ALK in anaplastic large B-cell lymphomas, and EBV, which will help us to identify a EBV-related DLBCL. So one important point to make is that if the morphology you're seeing is of a medium-sized atypical lymphoid population with a starry sky pattern, and IHC confirms a B cell NHL with a key index approaching almost 100%, CD10 is positive, c-MYC is strongly positive, but BCL2 is negative, think of Burkitt's lymphoma and advise the molecular studies. Next, coming to T-bar NK cell lymphomas, the essential marker should include 320 and Ki67, along with additional T lineage markers of CD5 and CD7. So NK bar T cell lymphoma, you would suspect when you have a population of atypical medium-sized lymphoid cells with highly irregular nuclear outlines in a polymorphous inflammatory background, including eosinophils and a proliferation of high endothelial venules. So subcategorization markers include aberrant expression of CD4, CD8, CD56, CD30, ALK, demonstration of cytotoxic proteins like TIA and granzyme B, T follicular helper cell markers like PDL1, CD10, and BCL6, clonality markers like TCR delta and also EBV. So these are just pictorial representations of a few lymphomas. So the ALK positive ALCL, you have to remember that they will be very strongly positive for CD30 and ALK, but they may be negative for the lineage marker CD3. So in such cases, you may have to apply additional T cell lineage markers to like CD2, CD5 or CD7, etc. So next, this is a case of angioimmunoblastic T cell lymphoma, where you have a mixed pattern of CD3 and CD20 proliferation, along with hyperplastic follicular dendritic cell network, and the background showing a few scattered EBV positive cells. This is an example of an extranodal NK bar T cell lymphoma. Here in these lymphomas, the tumor cells themselves are positive for EBV, and they are of T lineage, that is CD3 will be positive and CD79 will be negative. Coming to precursor lymphomas, the precursor lymphomas are the B lymphoblastic lymphoma by leukemia and T lymphoblastic lymphoma leukemia. So if on morphology, the cells appear very blastoid or very immature, in order to pick up these tumors, along with the initial panel of CD3, CD20, and Ki67, you have to put in additional immature cell markers, that is TDT, CD99, to arrive at a diagnosis. When it comes to T lymphoblastic lymphoma, along with the CD99 and the TDT positivity, these cases almost always express CD3. So you can pick up the T lineage. But when it comes to the B lymphoblastic lymphomas, they may be negative for CD20. So in these cases, along with TDT, to pick up the B cell lineage, you need to add additional B cell markers like CD79A. Coming lastly to the Hodgkin lymphomas, as you know, here the morphology will be of a few or a minor population of large cells seen in a predominantly reactive cell background. So you have the classic Hodgkin's lymphoma and the NLPHL or the nodular lymphocyte predominant Hodgkin lymphoma. The essential markers to apply will include CD3, CD20, CD15, CD30, and PAX5, and EBV may be positive in some cases of Hodgkin's lymphoma. So as we know, the classic Hodgkin lymphoma Reed-Sternberg cell has a reduced or an absent B cell program. So what we are looking for is a strong membrane and Golgi body positivity for CD30 along with CD15 if it is helpful. It is almost confirmatory of a Hodgkin lymphoma. PAX5 will show a very dim variable positivity in the large cells. CD20 will be negative in the large cells, but sometimes they can show moderate amount of positivity. But be careful that it does not label it as a B cell lymphoma. If you have any doubt, you have to work up the case with additional B cell markers to rule out that it's not a B cell lymphoma rather than a Hodgkin lymphoma. Coming to NLPHL, in contrast to classic Hodgkin's lymphoma, in NLPHL, we know that the CD20 program is preserved. So it will be diffusely and strongly positive for CD20, the LP cells in NLPHL, and also other B cell transcription factors like OCT2 will be positive. CD30 will be negative or it can show focal positivity, and CD3 will be only scattered positivity in the background. Just to share a case with you, this was of a 63-year-old male presenting with bilateral cervical swelling and pain of 3 to 4 months. Peripheral blood showed the presence of blasts, and the flow cytometry came as acute myeloid leukemia. However, since the patient had very significant bilateral cervical lymph nodes, a lymph node biopsy was done to rule out a lymphoma. So on microscopy, you can see that there are residual follicles here, and the atypical infiltrate has effaced the architecture of the node, mostly in the interfollicular and the paracortical areas. And on higher power, they are looking very blast-like with plenty of mitosis, open chromatin. So on IHC, the CD3 and CD20 was positive only in the residual follicles inside the follicle and in the interfollicular area, while the infiltrate itself was negative. Since it was a known case of AML, we applied the myeloid markers, that is CD33 and MPO, which was diffusely positive, and also the immature myeloid cell marker, CD117, which was also positive. So this was a case of an extramedullary infiltration by acute myeloid leukemia in lymph node, otherwise what we call as a myeloid sarcoma. Next, the indications of role of IHC in carcinoma of unknown primary and the different identity of undifferentiated tumor will be taken in detail by the next speaker. So I just want to share a case of a interesting case. This was a 68-year-old male who presented with an ulceroproliferative growth noted in the anal verge extending up to 8 centimeters. So we received a colonoscopic biopsy. Here you can see the colonic mucosa, and here you can see the ulcerated tumor fragments. So the tumor was composed of just sheets and groups of very large polygonal cells having eosinophilic cytoplasm, very prominent inclusion-like eosinophilic nucleoli, and the stroma was scanty with only some mild lymphoplasmacytic infiltrate. We did not see any glandular pattern in the tumor or a neuroendocrine morphology. We Because of this morphology, we suspected a melanoma, but even on searching, we could not get any pigment. So anyway, with the three differentials in our mind, we did an IHC. So you can see that here, this is the colonic mucosa, which is a positive internal control for the pancytokeratin. The tumor was negative for cytokeratin, negative for the neuroendocrine marker synaptophysin, but beautifully positive for the melanoma markers. S100 showed strong cytoplasmic positivity. HMP45, though it was patchy, it showed a strong membrane positivity, and SOX10 showed a very strong and diffuse nuclear positivity. So it was a case of a mucosal melanoma. The next application of IHC is in identifying cases for which immune checkpoint inhibitor therapy can be ordered. So this is done by MMR bar MSI testing and or PDL1 testing. In an MMR IHC, what we are testing is for the four mismatch repair proteins, that is MLH1, PMS2, MSH2, and MSH6, to look for the loss of one or more of the proteins, which will label the tumor as dMMR or a deficient MMR. As we know, the microsatellite instability or the MSI high status is the result of a deficient mismatch repair protein program. And also, the presence of MSIH in a tumor tissue is also the hallmark of Lynch syndrome related tumors. So the MSI or MMR testing is generally carried out in tumors of the colorectum, small intestine, and stomach. And now protocols are also available for testing in endometrial carcinomas and ovarian carcinomas. However, generally in head and neck and lung tumors, PDL1 IHC for the programmed cell death ligand 1 protein is evaluated to identify patients who may benefit from immunotherapy. This is just an example, a case of an endometrial carcinoma where the MMR IHC was performed. So this was positive. We look for a nuclear positivity in the tumor cells. So it was strongly positive for all the four markers, MLH1, PMS2, MSH2, and MSH6, and the internal control of the stromal cells and the lymphocytes was also positive. So this was a MSS tumor with a preserved MMR program which showed retained nuclear staining pattern for the four proteins. A case to illustrate the role of IHC in the tissue diagnosis of infections. IHC basically complements the use of PCR in the diagnosis of infections, and it is of critical importance, especially when you receive transplant biopsies or in cases of immunocompromised patients. So this patient was a known case of ulcerative colitis. He presented to the emergency with severe loose stools, and endoscopy showed a severe pancolitis and deep ulcers in multiple sites of the colon. The CMV PCR was negative. So the clinical diagnosis was of an acute severe UC. We received a colonoscopic biopsy and it just showed mostly ulcerated fragments of colonic mucosa. However, in areas we could see this enlarged cytomegalic cells which were lining the endothelial spaces and had smudged inclusion like nucleus, which made us suspicious for a CMV. So, and the IHC for CMV came positive. You can see that it was positive for the CMV viral inclusions, mostly in the endothelial cells lining the blood vessels. So this was a case of a CMV infection in severe ulcerative colitis. Why is it important to identify is because the patient has to be initiated on antiviral therapy. Otherwise, he may not respond as expected to the treatment for a severe UC. Again, an example of an keratinizing squamous cell carcinoma of the cervix. The application of the surrogate marker for the high-risk HPV, that is P16, was diffusely block positive in this case. That means to say that it was diffusely and strongly positive in the cytoplasm and the nucleus. That is what is called as the block positivity in more than 70% of the tumor cells. And so this was subtyped as a HPV-associated cervical squamous cell carcinoma. Another interesting case of a miscellaneous use of IHCs, which we have come across, uh, this was a case of this was actually a pleural biopsy in a patient who presented with pleural effusion on evaluation for some gynec problems. And the biopsy actually showed sheets of plasma cells and also lymphoid aggregates along with a mild eosinophilia. And when we proceeded with the IHC for IgG4, we have to do the CD138 IHC. It was diffusely positive in the plasma cells, and most of these plasma cells were positive for the IgG4 IHC also. So the IgG4 plasma cells were positive in aggregates with more than 50 IgG4 positive cells per hyperfield and a IgG4 to IgG ratio of more than 40 in areas. So we could suggest a probable IgG4 related disease in this case. And on evaluation, the serum levels of IgG4 were also found to be elevated. The importance to recognize it as rather than labeling is at just a dense chronic inflammation is that these patients can respond very well to steroids, but if not picked up, they have a clinical course of remittent and reactivation leading to a more severe disease in future. And my last slide, the application of IHC for C4D to diagnose acute antibody mediated rejection in liver and renal allografts. We get transplant biopsies in our department, and the scoring for C4D positivity is dependent on the percentage of the portal vessels in a liver biopsy or peritubular capillaries in the renal biopsy. What we are looking for is this circumferential strong staining in most of the portals. Important to identify in liver allografts because it is not very common. AMR is not very common in liver transplants, and you have to identify it at the earliest for critical intervention. Otherwise, it may lead to a graft loss. So take home messages for IHC interpretation. Make sure that the positivity you are seeing is in the tumor cells and not in the background inflammatory or stromal cells. Be alert for the correct pattern and the location. Ideally, on-slide controls should be used along with the test and do not ignore negative controls. You repeat the test if it is needed. IHC has to be correlated with clinical picture and morphology since as antibodies can show positivity across tissue and tumor types. Thank you.
Thank you, Rachel, for a very extensive presentation and in such a short time covering almost every aspect of IHC markers that can be utilized for diagnosis.